Good morning.
Good morning. I guess we're already live streaming on YouTube, so YouTube audience, hang on. The meeting is not called to order yet. Right, you'll let me know if we have a quorum, right?
Yes, I will.
Okay, I think we're close. But... Morning, everyone. We're just verifying a quorum and then we'll get going. 12, 13. I see at least 13.
I think, yep, we're good, I think.
Okay. Are people still coming on or?
Yes, they are. I'm trying to gather them all. Yes, we need 11, so we're.
Need 11, okay. Okay. Well then, good morning, everybody. I'm going to call the cabinet meeting to order today, May 10th, I believe. Well, let me say that again. We're going to call the meeting to order. Good morning, everybody. It's nice to see everybody after session. We have a full agenda. I want to make sure before we get into our first agenda item, which will be the public comment, that we get a chance to introduce our new Medicaid director. I see he's on and Commissioner Gifford's on. So what I will do is hand it to Commissioner Gifford.
Thank you, Vicki. Good morning, everyone. Nice to see you all. Deidre Gifford from the Department of Social Services. I just wanted to introduce our new state Medicaid director, Guy Woolston, who's joining us this morning for the meeting. Guy has been on board with us for coming up on a month now, I think, and comes to us most recently from a leadership position at CVS Health, where he was working with their data and analytics unit. He has a background, he's an economist by training, and a background in health IT and data and analytics. So we're delighted to have him, and he'll be joining this group periodically. I also want to acknowledge Bill, who's on, Bill Halsey, who served as our interim Medicaid director and has been promoted to our deputy state Medicaid director. That's a new position for us in Connecticut. And we are thrilled and delighted that Bill has agreed to take on those additional leadership responsibilities. So look forward to having both of them work with this group. Thank you, E.D. Beltry.
Thank you, Commissioner Gifford, and welcome, Guy. And of course, welcome back, Bill, who we've known for a long time and worked with. So I'm happy to have you here along with everybody else this morning. So we have a pretty full agenda this morning. I'm relying on the participant list for people to know who's on. I hope that's sufficient for folks rather than going around. It would be hard to do that this morning. But so I will ask and move right into public comment and see if there's any public comment this morning at the meeting. If you are a member of the public, please raise your hand. You can use the Zoom function, and we will recognize you. I do not see any members of the public raising their hands. Okay, if you are the member of the public and you're trying to get in on public comment, please let us know. And we will try to make sure we accommodate you and come back to recognize you. So with that, we'll just move directly into approval of the March 8th, 2022 cabinet meeting minutes. Could I have a motion to approve the minutes, please?
Madam Chair, so moved. This is James Michelle.
Moved by James, seconded by Pat. Thank you very much. Are there any comments or questions about the meeting minutes? If not, I will call for a vote. All those in favor of approving the meeting minutes, please say aye.
Aye.
Are there any noes?
Aye.
Any abstentions? No. Okay, great. The meeting minutes carry. That motion carries. Thank you very much. And we will just move right into asking James Michelle, our Access Health CEO, to give us an update. So good morning, James. Thank you once again for being on and giving the cabinet an update.
Thank you, Madam Chair. I have several updates for the cabinet. I'll try to move through them as quickly as possible. First, the next slide, please. So quick update on where we are, what we are doing in preparation for Cover Connecticut between now and July. Again, we are having information sessions twice a week with our community partners to get them ready. And we've been sending out information about what's coming. We do that on a regular basis, but not right now. We are meeting on a regular basis with our partners in preparation for Cover Connecticut. This is the expanded Cover Connecticut starting in July. So that's ongoing. And we've also updated our web portal to provide more information, more timely information as the Cover Connecticut strategy evolves and develops. Just be aware that that's coming, and I would encourage you, go to our website if you wish to, and then look at it. If you have any feedback for us, we're happy to get your input and for any tweaking that we need to do. Thank you. Next slide.
Sorry, I'm trying to let people in. I'm doing a little bit of a couple of things.
We have been working on the public health emergency. We have been working very closely with DSS on a regular basis and OHS as we prepare for the end of our public health emergency. We know DSS is taking the lead on this, but Access Health has responsibility for the outreach and marketing, as historically 10% of redetermined DSS Medicaid recipients become Access Health customers. So we have a vested interest working very closely with DSS to make sure all those who will be redetermined once PHE ends, that they have the information that they need to stay covered, so that there's no interruption to their healthcare. Currently, we have again about 380,000 enrollees benefiting from the extended because of public health emergency. Right, currently is extended to July 31st, 2022. It's just been discussed. It may go beyond that, but as of now, we are planning as if it's going to end on July 31st. And we try to get updated information for all the customers, because no one has been redetermined. The 300 have not been redetermined. So it may be our data may not be accurate in the Access Health system with respect to expanded. They may have added people to their Medicaid. They may have moved. Their phone numbers may have changed. So we want to get updated information. So when we start communicating, doing outreach, sending letters and notices to them, that we have the most accurate information to connect with them. So that's where we are at public health emergency. But there's been ongoing coordination with DSS for almost a year now. It continues to be extended, and we are anticipating. We hope anticipating the further extension simply because July 31st, we will be in the midst of preparing for open enrollment, which kicks in November. So if this could go on to December 31st, which we have been communicating with CMS, they have not indicated which way they're going to go, but we're advocating for an extended, more extensions to PHE. At the very least, for our own personal benefit, in that it'll give us more time to coordinate between open enrollment for for November 1st, as well as the end of open at the end of the emergency, public health emergency. Next slide, please. Quick update on the Broker Academy. So far, we have in excess of 160 applicants. The application deadline was May 2nd, and we had some that came in. We had about 12 that came in over that weekend. We had 96 students accepted so far. They accepted mean that they went through the application process. We interviewed them, and we've done the background check, and we sent them a letter of acceptance. They've accepted it. So that's 96. We have right now we're up to about 20 students on the wait list, and again, this was prepared last over the weekend. Right now we're up to 100 fully staff for the entire. Again, for all 3 locations, we had planned on doing 100. We have 100 with about 20 that are on the wait list. You know, they've qualified. We just don't have the space for them. So since we started accepting students, we started weekly information sessions where students sign in. Well, we want to keep the communication going, keep them engaged. So we have these weekly information sessions where we're answering questions, and about 85% of folks who sign up show up to those sessions, and they're in the evenings. So we're very encouraged by the enthusiasm that the students have towards this. Again, just as a quick reminder, the training session will start June 1st. And we have picked 3 locations in the 3 major cities that's easily accessible by public transportation. We have Capital Community College in Hartford. We have Gateway in New Haven. We have Housatonic Community College in Bridgeport. And again, right now we're in the midst of updating Access Health laptops. So as we update those laptops, we are refurbishing the old ones, and we'll make them very functional and aesthetically pleasing, and we'll be distributing them to the students. Normally, we would have to pay somebody to take them away from us. We think this is a very good use of these it's still very usable laptop. They're just not strong enough for the work that we have to do in Access Health. After that training, between June and August, there will be ongoing self-study support because we have signed a contract with Kaplan to deliver the services, to do the training. The students will have ongoing access to study materials, practice exams from June through August, with the plan on them taking the exam and passing it by the end of August. And again, throughout June and August, we'll continue to connect with the students, supporting them, advising them, and making sure that they are progressing towards achieving the ultimate goal of getting a license to sell health and life insurance in the state of Connecticut. Mentorship program in August, again, later in August, from August, September and October, and we have a number of brokers that we are currently in discussions with to become mentors for the 100 students that would be trained and newly licensed students. Because one piece of data we do know is that to have success in this particular profession, you need to have individuals giving you guidance on how to grow the business, how to connect with the community, and so forth. And again, remember, the ultimate goal in doing this is to lower the uninsured in Connecticut by having licensed brokers who are informed, licensed, who will be able to share information, give access, and give guidance to historically deprived communities of color in the state of Connecticut, so that they will have access to timely information, so that it will continue to have access to health insurance. Again, also, all these brokers will be required to enroll people in Medicaid as well. So when someone shows up to any of our events, we don't know if they're Medicaid or QHP. So again, wherever you end up, as far as we're concerned, DSS is another insurance carrier. It's just so that it's free. So we would enroll anyone at all, and if they become an Anthem or Connecticut or DSS customer, so be it. So all of our customers are trained, all of our brokers are trained to enroll all of our customers who apply to Access Health in any of the three carriers in the exchange, and DSS happens to be our biggest carrier. So, Madam Chair, I would pause now and see if there are any questions for anything that I mentioned.
Thank you, James. Are there questions for James? I'm trying to look for hands, which is hard. There's a large group here today. Jill's raising her hand, I think. Jill, go ahead.
Yes, sorry. James, thanks for the update on the Broker Academy. How does the compensation work for brokers? It's great to hear that they're enrolling Medicaid. You know, we've always been great. Our state has been truly a no wrong door state, one of the few, I think. And so how does the compensation work for brokers? Because they only really get compensated if they sign someone up for the exchange, or is there a way that they're getting compensated for Medicaid too?
No, there's no compensation for Medicaid. Some states do pay for that, but Connecticut is not one of them, right? But we know that some of the applicants, students that we've admitted, they are from some of the DSS partners, community-based organization. Some of them do have contract with the state to provide the services. So there's maybe a back channel way of compensation for enrolling people. And a lot of them are currently certified application counselors, right? But brokers get compensated through commissions from when they write any insurance through the exchange or through any means. They get compensated. And right now we know on average, we know the commission is $15 per month per member. So conceptually, in some cases, in reality, if you enroll 1,000 customers to Access Health, you get $15 a month for each one of them. So that's $15,000. And this is a real possibility. If you work hard enough, you can make a pretty good living. And that's just health insurance. If you do other Medicare and other, you could even make more money if possible. We do think that this is an avenue, not just in terms of providing access to health insurance and being a local, knowledgeable person for the community to go to. We could also do quite well economically for you, for yourself and your family and your community. We do have some brokers who currently employ additional people from their community because their business have grown large enough where they need to hire more folks. So there's an economic development opportunity as part of the Broker Academy as well.
Thank you.
Hey, Vicky, one quick comment. We started doing more training because we've heard because last time we did cover Connecticut, a lot of hospital and other community-based organizations did not have the people resources to enroll folks. So we opened up a whole new training opportunity for certified application counselors. And we have 14 people that we are training right now through different organizations. And we normally do not do training during the year. We do it when we have in preparation for open enrollment. But we did a whole new training opportunity, and we have 14 individuals who've signed up who are going through training right now to become certified application counselors.
Great.
you.
Thank you, James.
Yes.
I think Ellen has her hand up. Go ahead, Ellen.
Yeah, that it is great. I agree with Jill. Just to confirm, they do get the funding for if they sign people up for Covered Connecticut. And also, can you just update us how many people are in that program now?
Cover Connecticut, last time I checked, and yesterday we had about 800. I'll give you the exact number if you give me a minute.
Okay. But the brokers get paid for signing
Yes.
people up for that as well.
Yeah, Cover Connecticut is an insurance product. They do get paid for that.
Okay, thank you.
Yeah, they got commission for that. I will give you Cover Connecticut right now as of today. as of yesterday, rather.
Want to take a bet?
824.
824. Thank
Yes,
you.
ma'am. Okay, that's as of yesterday, as of midnight this morning.
Okay, thank you.
Okay,
James, well,
Yes.
I'm gonna take the chair's prerogative and just say, Cover Connecticut, we're expecting, I think, and I know Commissioner Gifford's on, so I welcome her to comment, but I think where we're expecting the enrollment increase will be starting with the adult population that is eligible on July 1st. That's between just over the Medicaid limit of 138% of federal poverty up to 175. So that's where we're expecting an increase, and also on the redeterminations, potentially if people had higher incomes and stayed on Medicaid during that period. But I welcome, Commissioner Gifford, I don't know if you make any other comment besides that, but I open that up to you if you want to comment.
No, I agree completely, Vicki. It was we knew all along that this initial tranche of eligible residents was smaller, and that the larger eligible population available was in the adults without dependent children. And so that's where we expect to see the increases beginning this summer.
so Dr. Gifford, Vicki, thank you for that opportunity to talk about this. That's why we are doing very targeted outreach. Because we have the data, we know who the folks are, and based on the latest information we have about the income level, size of the family, we could pinpoint exactly who will qualify for the expanded Cover Connecticut coverage starting July 1. So this is why the outreach that we are doing, the marketing will be very targeted, email, text to those individuals, where to make sure that, first of all, there's no interruption in their coverage, because it'll be free for them. And so that's why there's a lot of outreach, and we're still going through the data to decipher who specifically would qualify on day one. And we contact them today, May, June, so that July 1st, there's no interruption to their coverage. We just have to update our data to make sure it's accurate, because they have not touched their application, some of them in close to 2 years. So we are going to use the latest data that we have in our system to identify who they are and reach out to them directly, either by text, phone, and letters. In some cases, go right into communities where there's a heavy concentration of that population, to work with the community organizations to make sure that they know there's no need to avoid coverage and potentially impact your quality of health.
Great, thank you so much, James. Any further comments or questions for James? Scrolling through the names. I don't see any other hands. Speak up if I missed you, but I don't see any hands. So, okay, thank you so much, James, for that update.
You're welcome. Thank you.
We are going to move on next to a presentation from Gloria Sancho from OHS on the Connecticut Emergency Visit Dashboard. So Gloria, good morning. Hopefully we can display your deck and you'll be off to the races.
Yes. Okay, 1 second, please. Good morning, everybody. Okay. Okay. Today, I'm going to demonstrate to you our newly created emergency room utilization dashboard. The purpose of this dashboard is to provide concise answers to NN utilization related, data related questions that you may have. The database breaks out statewide utilizations by primary payer race, ethnicity, and also age group. We also have included avoidable ED, potentially avoidable ED visits, the top 10, the top 10 ED visits, and also the top 10 primary reasons for avoidable ED visits. The database does not include Sharon Hospital, and the reason is Sharon Hospital submits the following separate from the other hospitals and also in a different format. We are working on that information to incorporate it with other data sets. However, Sharon Hospital, the data over the years, the average ED visits run between 6 and 11,000 visits a year. And those visits actually, for this analysis, didn't pose any significant difference in what we have to present today. We have a link here also to de-identifiable patient data sets. And our table of contents right now, I will click on each one and I will walk you through the setup and how it displays the individual groups compared to what was compared to statewide numbers. So our first group would be the race and ethnicity. Okay, the first bottom charts, figure 4, 5, and 6, displayed statewide numbers. And figure 1, 2, and 3, those are the individual groups. As you can see here, we have broken out race and ethnicity by the 4 different groups. So I will go over the statewide, and then I will take you over the individual group as it compares to the state, their share of statewide visits. So over the years between 2016 and 2021, as you can see, we had 1.5 million visits in 2016 versus 1.3 million visits in 2021. The change between those years is 18%. However, we noticed a big drop between 2019 and 2020, which is that within that 1 year, we had 16% drop. And this is pretty much because of the COVID pandemic that we had. And the numbers so far is still lower than to date. The ED visits is still lower than pre-COVID years, as you can see for figure number 4. Figure number 5 is the overall, again, this is all statewide visit, and we broke it down by treated and admitted and treated and discharged. And we show that overall, over the years, we have basically close to 85% or so people that were treated and discharged versus 15%, which has been pretty low, between 18 and it decreased to 15%. I'm sorry, this chart should have been flipped the other way, but it's between 18% to 15% from 2016 to 2021. Those were people that were treated and admitted as inpatient. The chart number 6, statewide numbers show again, we broke out the time of the day that people visited the emergency room into 3 time areas, blocks. And we noticed that over 50%, almost 60% of the people visited the ED pretty much between regular business hours. And it was also, our analysis also showed that Medicare was the primary payer for those visits. and also showed that most people went between 11 o'clock and 3 o'clock. That was the chunk of the time that the chunk of the people went within that time, visited the emergency room. I will move over to the top of the screen. Figure 1, 2, and 3. Those are the individual groups. And I will explain to you how they compare to a statewide visit. Figure 1 here, we show that for Blacks, non-Hispanic, over the years, ED visits have been pretty much constant around 16, 17%. And compared to 2021, we show that 16% out of the 60% Black non-Hispanic visited the ED. Figure number 2, we broke that down similar to treated and admitted versus treated and discharged for this particular group. And we show that pretty much 40% of the Black non-Hispanic were treated and discharged from ED versus basic of barely 2%. Now, our next chart showed that their share of the ED visits when it came to the time of visit in their time of admissions at the ED. And we show the same as statewide, we show that 9% of the total visits, of the 16%, 9% of those people visited the ED between 8 and 5 p.m. I'll move over to our next group. And we show that, one second, please, I'm trying to. Hispanics. Hispanics is the second largest group when it comes to ED visits, following non-white non-Hispanics. Also, it shows that Hispanics were 24% for 2021, 24% of those ED visits were Hispanics, meaning that 1 out of 4 persons, Hispanic person, went to the ED. Okay, and the next chart shows that their share of the ED visits, when it comes to treated and admitted and treated and discharged, we show that 21% of those visits of patients, those visits were people that were treated and discharged. The next chart also shows, compared to statewide, 14% of the Hispanics visited the ED during regular business hours, and barely 10% went on the odd hours between after 5 o'clock to 7 a.m. They visited. So we had a majority, almost over 50% of those people that were visited the ED during working hours, whereas they could have gone to primary care, but for whatever reason, again, we found out that Medicaid was the primary payer when it comes to people visiting EDs during those hours, was the primary payer. Other races has the smallest unit when it comes to ED visit. They visited, fewer people from other races visited the ED. As we can see, the numbers is pretty much been the same, 5% compared to the overall statewide, just 5% of those people visited the ED. And out of the 5%, pretty much all of them were discharged to treated and discharged. And also similarly, even though we have 3% visiting the ED during business hours, but pretty much the numbers were so low that basically it probably was fluctuating, but we have a few people going in midnight versus during the midnight to early morning versus after 6 p.m. And the white non-Hispanics is our largest group of people that visited the ED. We have almost 50% of the ED visits were white and white non-Hispanic. Again, out of that, we had 82 for 2021. We had basically 42% of those, the group white non-Hispanic who were treated and discharged. Out of the 80% group that were treated and discharged, we have 42% that were white non-Hispanic. Again, we have the same numbers flowing statewide. We had a lot of people going in through visiting ED during business hours, and we see the same numbers, high numbers, which was 32%, pretty much constant over the years, pretty much constant when it comes to the other hours. During the time, they're pretty much the same numbers that was flowing through from 2016 to 2021. Our next group of an analysis, we did analyze primary payer. We broke out the primary payer group and analyzed that compared to statewide. And we saw that basically we broke it down by these 5 different groups. And when it came to commercial payer, again, we had 28% out of those people that were paid by, had a commercial payer as a primary payer. In addition to that, we had 25% of those, 25% commercial payers, that people that were commercial payers out of that were treated and discharged out of the 85% group statewide that were treated and discharged. Again, as we said, again, same story, we had over 50%, which was commercial payers, visits as 16% statewide, which is pretty much like 58% statewide, and commercial overall 58%, but commercial during 8 a.m. and 6 p.m. Commercial payers people were around 16% that visited the ED. Medicaid visits accounted for 81% of the total statewide visit. Treated and admitted or treated and discharged, we had 34% in 2021. Out of the 85%, we have pretty much 34% of those people that were treated and discharged. Where statewide, we have 15%, but just a little like 4% were treated and been and admitted for Medicaid payers. Again, as we can see, the top chart versus the bottom, we have 21%. I'm stressing on the time between 8 a.m. and 6 o'clock, because basically there was business hours where people could go to a primary care facility. But basically, we have 21% out of the 58% of the statewide people that visited the ED during those hours. Medicare, our next payer, we see incline over the years. And basically, we had statewide, we had 27% out of all of those visits were Medicaid. And out of those 17%, we have 27% statewide. They are 85% of the people that were treated and discharged. We had 17% of them that were paid by Medicare, was the primary payer. Again, we still have numbers like 16% for Medicare payer versus the 58% that visited the ED during the regular business hours. Other public, we have a very, very like 1%, as you see, we barely had, and then visits when it comes to that over the years, it's been pretty much constant. But again, the scenario is there 1% of those people that were from other insurance, other public insurance of 1%. And basically, they were all treated and discharged, as we can see, versus the 85% of the people that are statewide. And basically, they found themselves, those people really were visiting the ED after 6 p.m. and between 6 p.m. and 7:59 a.m. Basically, they all went to the ED versus the other payers that we say, the other visits. On this show, we say that it's a slight decline, but we had for on people that were not insured, so to say over the years, it's been between 6 or 7% statewide. And basically the same scenario that out of the treated people that were treated and discharged, we had 6%, out of the 85%, we had only 6% of those people that would only show that were treated and discharged. The time of admissions in the ED, we basically had we have the majority of the people visiting during business hours, again, 4% compared to the 58% statewide. Our next information will be on age group. And we broke their data down by these 4 categories, age categories. And we say that 1 out of 4 persons, close to 1 out of 4 persons that were I'm sorry, I'm going to start from age less than 18. Okay, we see that there was 13% of those people that age under 18 that visited the ED. And we also say that it's same as though all of those in 2021, we had nobody treated and admitted. Basically a few people, but we show that 13% of those people were treated and discharged versus the 85%. And we also see a big decline in this group of this age group. From 2016, we see a big decline in ED visits. And also that big decline also comes to when it comes to over the years, we've seen that fewer people in this age group visited the ED, and especially between 2020 and 21, we had a drop within the regular business hours between the regular business hours. Yeah, so I'm sorry, we say that the regular business hours is dropped 1%, but we've seen it also drop between 6 p.m. and 8 and midnight we also seen a big drop also in the ED visits. Our next age group is 18, between 18 and people that were 18 and 24. We see that again, 37% is pretty much just about 1 out of 3 persons. This is pretty much our largest group when it comes to ED visits. 1 out of 3 persons almost visited the ED. And pretty much we had, out of those visits, we had 3% of that group in 2021 that were treated and admitted as inpatient versus the other 34% that were treated and discharged home. Again, we had pretty much a decline, a big decline from 2016 to 2021, a big decline in ED visits with these people in this age group. And we're also seeing that they frequent the emergency room pretty much the same time between 8 a.m. and 6 p.m., but we're also seeing a decline over the years for this group. Age 45 to 64, again, we have 26% of people within this group, in this age group that visited the ED versus statewide. And again, a decline. It's been pretty much constant when it comes to over the years. As you can see, it actually from 2016 to 2021 is actually just a 1% increase. And as we can see over the years, basically we've been having like 21% of those people that were treated and discharged. Again, we have the same scenario statewide. It goes over every payer, every age group. We have majority of the people that visited the ED during regular business hours. All in all, it's been pretty much constant between 15 and 16% percent of those people that visited the ED during regular business hours. Our next age group, again, is 1 out of 4 persons that visited the ED, but we had pretty much 50% in 2021 that were treated and discharged, 9% for 2021, 9% were treated and admitted as inpatient. And we said, again, a big jump, a graduate jump of visits that come, people that visited the ED between 8 a.m. and 6 o'clock. We're saying from 2016, where 11%, 9 is 15%.
So Gloria, can I just jump in and ask a question on this? So
Yes.
just so people aren't misreading some of the
Okay.
charts,
All right.
or it's something that may be intuitively misleading is like being treated and discharged, like an
Yes.
ED non-admission. So in 2021, we show that lots of kids under 18, like there were 0 admitted, even though we know there's a behavioral health crisis going on, right? So
Yes.
lots of those kids may not have been admitted, but sitting in the ED awaiting, an inpatient bed somewhere or
Yes.
another location, right? So,
Right.
but they would show up, they
Right.
would not show up as an inpatient admission unless they actually went into that inpatient. So they could have been sitting in an ED for like, as we know, for a
Yes.
week or two before
Right.
finding something. So I want to make sure that we're reading it right, or people understand that could be the case.
Yeah, that's correct. Yeah, that's correct. Yeah. So our next scenario would be, we've listed the top 10 reasons, primary reasons. We use the primary diagnosis code, and as we can see, COVID was the for fiscal year 2020, 2021, COVID was the primary reasons for ED visits. Our top 10 primary reasons for ED visits shows that 15% out of the total statewide ED visits. So we had chest pain, again, chest-related headache, and so on. Those were the top 10 primary reasons. We have also broke down the data classified the data into potentially avoidable emergency room visits. And we use as you have seen earlier, we used the algorithm that was provided by the New York University. One second here, please. New York University Center for Health and Public Service algorithm. We have the algorithm that we use, and we populated it into the database, and we were able to capture those visits that fall into basically 4 major categories that we classify as potentially avoidable ED visits. And these are the classification, and other than drug, alcohol, psych, and injuries, our potentially avoidable EDs were non-emergent, emergent primary care treatable, and emergent ED care needed, but yet it was preventable and avoidable. Those were pretty much the potentially avoidable EDs. And non-emergent visits were classified as if the patient, based on the patient's complaints, symptoms, vital signs, medical history, age, indicated that immediate care was not required within 12 hours. Emergent primary care treatable. This information was based on the patients when they visited the ED, the records, but it also showed that treatment was required within 12 hours, but care could have been provided effectively and safely in a primary care setting. An example of this group would be somebody didn't go to the primary care, but they needed a CAT scan or certain lab tests. Those fall into that, just a few of the examples. The emergent ED care needed preventable and avoidable. That is where the emergency care was required based on the complaint or procedures performed and the resources used. But an example of this would be like flare-ups of asthma, diabetes, congestive heart failure. But our last category is emergent ED care needed. It was not preventable. It could not have been avoidable. And this is typical example would be the trauma, appendicitis, and myocardial infarctions. These are the avoidable ED classifications that we use to break out our data, and we compare 2021 versus 2020, and we see that pretty much it fluctuates it changes depending on the different classifications, but this is how we group the data going forward.
So Gloria, I'm just gonna interrupt for a second because there's a special guest on, Representative Pettit. Dr. Pettit is on, and he wanted to ask a question, so I'm gonna let him ask his question. Okay.
Thank you. Maybe down in the weeds at some level, but when you put up the avoidable ED visits, do you separately track the EDs that have a fast track primary care when the triage is done out front and they're sent into fast track versus sent to the active ER? Or does anyone who shows up, regardless of which track they go in, are they counted as an ED visit? Do you segregate those types of visits?
Well, based on the algorithm we use, we only ran the algorithm in our data set. So when it comes to tracking down and other information that could have been provided, we only ran the algorithm and we got these totals based on that. Olga, could you add on to that?
I missed, good morning. I'm in a hotel lobby, so there's a lot of background noise. I barely can hear. So I missed the question. I'm sorry.
I think the question is basically if there's an ED that has sort of like a triage, a fast track kind of area versus a full ED, people going directly into that major or the main part of the ED. Is there a differentiation in terms of the data? If somebody enters that space, it's just ED period, right?
We don't have the ability to track that in the ED database. So if the person was triaged to urgent care, for instance, that is not noted in the ED database.
So they're counted as a typical ER, even if they go to fast track and get a strep test and get sent on their way in 15 minutes.
Yes, we have no way of tracking, yes. And I should also say that the ED database is before reimbursement. So even if the individual is charged urgent care rates, we will not be able to tell from the ED database because this is basically who showed up in the ED and got some treatment or was triaged out of the ED.
Thank you.
You're welcome.
Okay. Our next group is, again, these are potentially avoidable ED visits. And what we have done here, we capture the data based on not comparing statewide, but we just group the data based on the avoidable ED, again, like what we saw previously, the information that we capture and identify as potentially avoidable EDs. So we group that statewide visit. As we can see, our potential in that those group of people that could have gone someplace else but went to the ED, we see that the number has dropped tremendously from 40% to 33% and still declining. And basically was the same pretty much until 2019. Again, because of COVID, we saw a drop in ED visits, and it's still declining from 2020 to 2021. That's a figure one. Figure two, again, we group all of those potentially ED visits again, and we group them by payer. And we show that Medicaid pretty much had from 2016 with 20%, and it dropped basically a little less than 15% in 2021. But we identified the payers and the percentage, the share of the avoidable ED when it came statewide. Our figure number three, we group again those avoidable visits into age group. And we see basically that age 18 to 45 is the largest group. Even though they dropped again, their visits dropped from 2016, dropped to about 3% down to 2021. But age 18 to 44 was the largest group, and we're seeing that age 45 and over pretty much were constant. Again, under 18 was our smallest group of people that visited the ED. Slide number 4 is avoided by ED by time of visits. Again, as we showed in the different charts previously, we're showing the same trend that a lot of people went to the ED between 8 a.m. and 6 o'clock. But we're also seeing a drop in the visits over the years and the time of the day over the years that people visited the ED. Chart number 5, we capture the numbers in the middle group here that's between 8 a.m. and 5 p.m. We captured all of those visits and we broke them down by payer. And we're showing that, again, Medicaid was our largest visits. Medicare was the most popular payer in the group. And also that the numbers have declined over the years, especially with Medicaid, but pretty much have been constant for commercial payers. And basically these are visits that were within that specific time frame. We capture also data by race, ethnicity, and we show that white is non-Hispanics frequented the ED more than the other groups, but Hispanic actually was the largest group, and that number declined over the years. And white Hispanic was the next group of people that frequented the ED. But all in all, our numbers have been declining, as we can see from chart number 1, from 40% to 33% over the years. And as we can see from between 2019 to 2020, it dropped from 39% to like 33% when it comes to the overall ED visits. We also captured 10 primary reasons for ED visits. And we compared that to the 10 reasons that people visited the ED, and this is avoided by EDs. And we compared the diagnosis, and we say that pretty much out of these 10, about 7 or 8 of these diagnoses were also captured in the 10 reasons why people visited the ED. But listed, we have 24% out of the statewide ED visits, and we have statewide avoided by ED visits of about 477,000. That's our total statewide ED visits. And we also, our last group here is we broke down ED visits per year, how people frequent the emergency room. And we found out that we broke it down, and we broke down the data, and we found out that the entire data set for 2021, we had 2,749 unique patients where we captured the MRIN and the MRIN, and were able to find out the total unique patients. It also shows about 27% of those people had less than 4% visits per year. And also, about 2,749% mixed up 11 plus visits per year, but we had about 24% of Connecticut residents, and we had we captured about 847,000 unique ED patients. So we have a chart here to show per visits, number of visits, and we have the majority is just one visit per year. We have like 73%. The other ones greater than we capture over 11 plus visits, which was less than 3%. So that's the end of my demonstration and our dashboard.
I have some questions. So, so thank you, Gloria and Olga for being on. So before we get to a couple questions, I just want to clarify a couple things with people. So first of all, going back to race and ethnicity, these categories that we're getting a race ethnicity are reported to us via the hospital data. So when we start capturing REL, data under what we call Senate Bill 1 from last year, or Public Act 2135, depending on what you want to talk about it, or how you describe it, these data will be more, in my opinion, more accurate because they will be capturing patient reflected data that the providers capture as a requirement of that legislation. So that's one thing I wanted to say. So these data are just coming to us right now from the hospital data system.
Right. Yes,
So,
that's correct.
second thing is this dashboard on our website?
No, not as yet, but it will be in. We
The plan is
Alright.
to post it. Yeah, we'll be posting it on our website. Yeah.
Okay, and then the third thing is, one of the things I know people will ask about is cross comparisons between tabs and being able to, in the old days, we would say pivot tables or whatever, whatever you
Yeah,
want to call it, where you could, compare the data by different categories. And I know that's something that we've talked about, and I think you're all looking at doing, right? I just want to put that out there because I'm sure that people will want to be able to do that at some point.
Yeah, so what we tried to do with this dashboard was to compare the categories, the subcategories of demographic group to the state and show their share of the statewide total. But we are thinking of also providing the ability to compare what's happening between and subcategories. So when you take race, ethnicity, for instance, you'd be able to compare Black, non-Hispanics versus Hispanics and other races and white non-Hispanics. So you would have them displayed together so you would see their relative share of the statewide total.
Okay, well, let's go to questions and we'll start with Guy and then go to Ellen. Those are the two I see on my screen right now.
Great, thank you so much, Gloria and Olga. It's really helpful to see this data presented in this way. One just quick clarifying question. I'm trying to get a sense of the overall magnitude in terms of dollars spent on this. And forgive me, I didn't catch at the beginning the data that you're using. Do you have an estimate across all payer sources for the total amount that is spent on avoidable ED, or does your data not include the dollar amounts?
So I can respond to that. I happen to look at the financial data as well. So I do know that in 2019, ED payments were 1.2 billion. And in 2020, ED payments were 1.05 billion. So if ED potentially avoidable ED visits are 40% of ED visits, we would say that's about 40% of the 1.2 billion.
Although that could be, right, that's assuming a linear relationship between.
And
the-
linear, that's right, yes,
So,
yes.
That's, but I think I think that data, I don't think we have that full data at this point, Guy, because I think we're doing the avoidable hospitalization analysis ourselves, and we have total ED data.
Yeah.
But we don't have, even in the APCD, we don't have all of that data.
All
We
of
only
that,
have
yeah.
the fully insured, right? But as part of the other process that we're collecting data, we'll have more data, I think, about ED. I don't know if it'll be split out by ED, but I hope it will.
Yeah, the ED data is mostly charge data, and sometimes we use a cost to charge ratio to determine what and the cost is. But yes, and like I said, it's data before reimbursements, the databases before reimbursement. So if there's been any changes, the database does not capture that.
Thank you. That's helpful. And the context of my asking, so this obviously is really useful. It's useful for shining a light, focused on Medicaid in my role, but it's useful for shining a light on some of the places where, as we're thinking about primary care reform, we might want to look. In my past life, I've led programs to try to educate members about alternatives to ED for members that we predict are likely to go to the emergency department unnecessarily. So anyway, thank you. This is very helpful for getting a sense of the magnitude of the problem here in Connecticut. Thanks again.
You're welcome.
Thank you, Pete. And I'll go to Ellen and then Pat.
Yeah, this is really interesting, and I'm going to be hurting my head for a while, spending a lot of time. I always love new data. So a bunch of thoughts, and then a question. It's really remarkable that 40% of our ED visits are avoidable. That's disturbing. And so I'm very glad you're doing this. And I think that would be really important for the cabinet to follow up on. I think the preponderance of Medicaid members who are going, especially avoidably, is something that should go back to MAPOC. I would love to have that discussion, and maybe a drill down more into the Medicaid numbers. Whatever you can give us would be really helpful, because I'd like to get sort of the expertise of the people around that table to think about how to work on those kinds of things that they were talking about, education programs, but also provider issues. There's just a lot to go to unbury there. I'm really struck by the fact that avoidable visits went down from 40% to 33% of a smaller number with COVID. And I wonder how much of that is because access might have been better with telehealth, better than it was before telehealth without COVID. And that's really interesting. And I'm sure there's no way in your database to figure that out. But if we could look at those, and correlation is not causation, but if they both happened at the same time, that's a clue that we need to make sure that that stays in place and is part of the solution going forward. So my question is this data downloadable? Can we get, I don't want identifiable data, but there's a lot of other ways I'd love to look at this and think about it. Is that going to be available when you get it online?
So I believe Maida sent you this dashboard earlier on, I think yesterday or last week. And the data that supports this is in there as a hidden file. So if you put your cursor on any of the tabs and you right click, you can say unhide, and you would find the base data there.
Okay, and is it downloadable?
Yes.
Or is it, okay, it's not like a pop-up and I have to copy down because...
It's an Excel worksheet, yeah.
Oh, thank you. My interns, thank you.
You're welcome.
Thanks.
Good questions. Pat?
Yes, thank you. Again, I echo what my colleagues have said about how important this data is, but I really want to go echo what Ellen said, which is what we do with the data is most important now. This is critically important for shining a light on it, but I do think it is something we need to think about, and maybe across agencies regarding initiatives that can make a difference. And I know that it'd be, I think, really important for the primary care work that we want to do, because at least when I was around, we found that people of color, that just through Access Health kind of snapshot one year, that only 46% of African Americans and Hispanics had a primary care provider as they came into the system. So again, this is terrific and absolutely critical that we need it, and the trend lines are important. And what we think about as our goals and doing next are equally important if we're going to translate this data into progress.
Obvious comment. There's really not to say other than that is the plan. You know, bringing these data sets together is really critical because this is one set of data, but it's not all. And, you know, as Guy was asking for about the cost side of the equation, and then the other, you know, obviously there's a quality component that needs to be brought to bear. They need to be brought together. And that's, I think, one of the things we're trying to do with an overall data use strategy. But I do agree that some of this data, I think, also could be shared with the MAPOC. And you know, we're happy to make that available for the MAPOC and for DSS, obviously, to have at their disposal for that analysis. So we look forward to the use of these data along with other data. So I want to thank Gloria and Olga. Is there anybody else who has a question, though, before we move on to the next agenda item at this point? No. Well, thank you, Olga, for pointing out the hidden file. That was very helpful, actually. I did not know that. That's very useful, actually. So with that, I want to thank you guys for presenting. We very much appreciate it. And we will move on to our next item, which will be a legislative update by Claudio Gualtieri is here, and he's going to give that update.
Thanks, Vicki, and thanks, Maida, for helping me with sharing and presenting the slides. So if we're starting, I know we have limited time today, so I'll start by saying that I appreciate this opportunity to give at least a landscape analysis and maybe whet the appetite of the cabinet members for where we may want to do some deep dives and think strategically and have work sessions on any of a number of the policy changes or ARPA and general fund investments that we made this session. So if we go to the next slide, you'll see just by the numbers, the 2022 legislative session was the shortest of all possible short sessions at just 85 days long. That, however, did not inhibit us from making very sizable investments in behavioral health, social services, and it didn't inhibit our ability to tackle a broad array of policy issues, some of which we'll hit on here today. I also call out the Public Health Committee because I was just so impressed at, in a short session, moving 53 bills out of committee that were of original jurisdiction. And when I talked to Representative Steinberg with about 2 days to go in the legislative session, his batting average was about near 70% of those bills and concepts had either passed or incorporated into larger bills and had passed. So very productive public health group. And I know, Dr. Pettit, that must be also a credit to your leadership on that committee and bipartisan support. If we go to the next slide, I'll just touch on the big topics we will discuss in our morning here together. I want to hit on some of the key budget investments that we make in the newly revised biennium budget. I want to hit on a few of the governor's bills that were passed by the legislature, and then tackle a couple of the bills as they relate to our health delivery system, Medicaid and private insurance, and a few other public health initiatives that I think are important to note. So starting with, on the next slide, our behavioral health investments. This was certainly the biggest focus, and appropriately so, coming out of the pandemic. I think we all saw the acute need for more investments in children's behavioral health and behavioral health generally. So very pleased to say that with bipartisan support and the governor's leadership, we were able to invest $300 million over the biennium. That represents a 10% increase from the previous biennium. So a very sizable amount of increases there. A focus was on creating alternatives to inpatient care. So you'll notice that we put investments in mobile crisis on both the adult and the pediatric side. This will allow us to create statewide 24/7 coverage. In the first part of the biennium last year, we did do some expansion that allowed for 24/7 coverage, but it wasn't uniform and it wasn't statewide. And we thought that for a more rapid response time and for statewide uniform coverage, further investments were merited, which we did here. In addition, DCF is going to purposefully create more strong linkages between mobile crisis on the pediatric side and schools, and also develop those linkages and partnerships with police and law enforcement. In addition, when we talk about building out alternatives to inpatient, DCF is going to operationalize new set of standards for urgent crisis centers, and those urgent crisis centers will have, as part of their pairing, subacute capacity for children and youth who need additional stabilization. So this will be a way to divert someone who maybe needs 24/7 care or respite opportunities, or up to about 2 weeks of care at a subacute level that doesn't need to go to an emergency department or require inpatient services. Really thankful for some additional investments early and upstream. DSS identified a need for infant and early childhood. I give a lot of credit to Commissioner Gifford here for recognizing that we really do need to build out a stronger cadre of service providers that can work with parents and youth at the attachment level, those early emotional attachment relationships between a child and their primary caregiver figure, and help understand and regulate emotion and mood. That's going to be really helpful for us to avoid more serious and complex issues later on in life. Also, universal home visits. Last year, we did put investments in. A number of our agencies came together and thought that this was critically important investment, early upstream intervention to avoid some of the more complex problems later on by having light touch visits and passing off to community health workers who could help new parents navigate the social network system, the healthcare system, and get the services that they need. This year, we added new investments to look at sustaining this model. So there's a pilot program in Bridgeport that's been in development for a while, and we're eager that those additional money to look at sustainability through Medicaid and private insurance, and for planned future expansions across the state. The Senate Bill 1, Senate Bill 2, and 5001 also made available a number of grant opportunities. These grants fell into a various array of categories. A lot of them dealt with how do we make sure that families, parents can get access to supports where coverage gaps existed, where insurance wasn't covering the appropriate level of care, or some of the out-of-pocket costs for prescriptions that were more costly. So they're family service type grants. There's also pilot programs to build out social workers and support the additional hiring of social workers at federally qualified health centers and in pediatric offices. Really happy, especially after hearing our presentation just earlier from the Office of Health Strategy on the backlog of EDs. That was a pressing concern throughout the pandemic, and it continues to remain an issue where in some cases people do need inpatient level of care, especially children. And there has been historically a little bit of a backlog at Children's Medical. They don't have the inpatient capacity to take people in once they're in an ED, so they rely on other hospitals and peers to admit those children who need inpatient behavioral health treatment. Now, for the first time, with a $15 million investment from the state, CCMC is going to be building out a 12-unit med psych unit that's, I think, going to be very helpful for decompressing the EDs and making sure that we're reducing wait times in our EDs when children have behavioral health needs. So very important investments across behavioral health. If we move to the next slide, I want to just hit on the investments in building out the infrastructure only works if the workforce is also there to deliver the care and deliver the services. That's why there's an array of investments being made to build out our healthcare pipeline. We know that it's very important to look at faculty and development in school programs. So there's funding for CSCUs to do healthcare workforce development. There's also a recognition that the student loan repayment program that was first seeded with a small grant in last year's session should be expanded and include behavioral health providers. So we're expanding out the student loan repayment program by the Department of Public Health to include a broader range of providers, including behavioral health, and help target those investments to underserved communities. There's also very significantly, our private provider network has raised the concerns of having vacancies and not being able to hire and retain staff to deliver our human services programs. And on top of last year's 4% cost of living adjustment, the legislature appropriated money in the budget this year to give an additional 5.5% COLA plus significant one-time stabilizations and grant supports to our private provider network. I think in total, when you look at that over just this biennium, it's so significant considering that there's been periods of over 10 years where nonprofit providers have gotten little to no, virtually no adjustment and increase. So that's going to help immediately infuse cash and resources to hire up and to retain and keep those high quality workers that are delivering a bulk of our human services programming. If we move to the next slide, I'll touch on additional human services investments. The autism waiver waitlist, we know that that's significant, but we were able to make a contribution to adding 150 new slots. That's going to help people, 150 individuals and their families immediately access services and help alleviate some of the pressure on the wait list. We also wanted to make sure that there were investments in community engagement. So DDS facilities will be getting some infusion of support and resources to help facilitate socialization and connection for those individuals with intellectual and developmental disabilities. Also want to stress here some of the studies that we're doing. We know that part of what we have the good fortune to do with the federal ARPA money is to investigate and pilot new and innovative ways to deliver care and services. But it also means that I think we have a unique opportunity to collect data and make sure that we're using money wisely and most effectively. So looking forward to the funding that's been dedicated to Office of Health Strategy to look at telehealth capacity and also look at how we may be able to ensure better parity between private insurance coverage for behavioral health and our Medicaid programs. If we move on to our next slide, we can touch on some of the governor's big initiatives. Again, here I have to really thank the Public Health Committee. Many of these bills went through public health. Not only did they have and enjoy bipartisan support, but I think in many ways, each of them benefited from contributions, feedback, and really rolling up your sleeves and ideas that legislators on that committee had for us. And pleased that it was a collaborative process. On the first, with reducing lead poisoning, this bill will strengthen standards that prevent childhood lead poisoning. Generally speaking, it reduces the blood levels that trigger various actions. So we move from 10 micrograms per deciliter to 3.5 micrograms per deciliter, the threshold to report to DPH and to local health. We also reduce the action levels for informing parents of different programs, including birth to 3, and other ways and strategies that parents can mitigate the dangers of lead and reduce risk for their children. Obviously, there's also a phasing in of the threshold to conduct epidemiological investigations and on-site remediation. Important to this bill was a companion piece of funding in the ARPA plan that was enrolled into the budget, $30 million to help municipalities do the remediation in some of our older housing stock, especially those areas that are most high at risk with children living in them. So pleased that both the statutory framework to flip it so that we're not as passive in our monitoring of lead poisoning, but it's a much more aggressive, proactive posture that we're taking with this bill, and then also the funding to actually make the remediation happen. Another key piece of that from a sustainability standpoint is looking at ways that DSS through the Medicaid state plan may be able to support additional supports for those children who are on Medicaid and may be at risk of lead exposure. The compact bills. Early on, before the session started, I had an opportunity to talk about the working groups that were set up to look at a host of different licensure compacts. Connecticut at that time was one of very few states that didn't have any licensure compacts in place. Certainly there was a trend towards doing more compacts for telehealth facilitation, greater mobility across state lines. I'm pleased to say that we took a really deliberative approach, and the committee at that point recommended 2 compacts for enactment. They became governor's bills and were ultimately incorporated as part of SB 2, one of the main children behavioral health bills that was acted on this year. Compacts, licensure compacts in general fall under 2 camps. There are those that are under a mutual recognition model, and then a different subset of compacts follow an expedited licensure model. The physician compact is a expedited licensure model. So when you think of it, the best analogy I can give is sort of for those people who are helping loved ones, family members go through the college admission process, it would equivalent to a college common application. And for those of us that are frequent travelers and have the benefit of having a TSA PreCheck, TSA PreCheck is another analogy that you can consider when you're thinking about an expedited licensure model of compact. So basically, a qualifying physician under the physician compact is issued a letter of qualification from the Compact Commission that grants them opportunities to use a single online application to get full licensure in any of the compact states. Expedited licensure are usually acted on within 7 to 10 calendar days, and it eliminates, having a single application eliminates the need to reproduce a lot of the paperwork or the background documentation for each state licensing board separately. So certainly a streamlined approach that we think will build up and get us additional physicians in the state. Complementing that is the PsyPAC, or the Psychology Interjurisdictional Compact. This compact also is widely supported by a number of states. There's 31 states. Connecticut will become the 32 state. Although I need to refresh because there's 3 or 4 that are right at the finish line almost in neighboring states. So that number may go up in the coming weeks, but certainly at least 31 have already enacted, in Connecticut being the 32nd state. The PsyPAC is different than the physician compact in that it is a mutual recognition compact. So the difference here is that it grants actual privileges to practice via telehealth in any of the compact states. And there's also a limited ability for 30 days of practice in a remote state. And that's 30 days limited to a calendar year, where for emergency purposes, a provider can provide in-person coverage. The next, just moving on to the healthcare benchmark, I feel like with ED Veltri here, I'm probably going to tip to her. I'll just tease it up. This is a really important investment for trying to drive down better value, quality, and transparency in our healthcare system. It would codify Governor Lamont's Executive Order 5 and create a pathway for establishing quality benchmarks, primary care spending goals, and cost growth benchmarks. There's also in the legislation prescriptive details and timelines for the modification of those targets and the requirements for public input, vetting, and transparency. I kind of think this is equivalent to when Oliver Wendell Holmes said that a little sunshine disinfects of many things. I think that's the spirit and intent behind this to help curb some of the costs in our healthcare system. Vicki, did you want to add? I know this has been something that you guys have just really done a fantastic job leading, and I hope we're able to really get this in place and get going.
That really did a great summary. I would just say for this one, it went through the insurance committee. That's the only thing
Yes.
I'll add.
One of the few governor's bills. We had to share the wealth, so we did give this one to insurance. The final governor's bill I want to touch on is the opioid litigation proceeds. This is Governor's Bill 5044. It codifies the opioid settlement agreement and ensures that Connecticut's share of the $26 billion multi-state settlement. Connecticut is approximately getting 300 million of that. We're going to make sure with this legislation that it's deposited in a non-lapsing account and it's dedicated to evidence-based strategies and reinvestment. To ensure greater transparency and accountability, the legislation sets up an advisory board that's comprised of a representative sample of stakeholders, equally divided between municipal representatives and those with expertise at the state level and with lived experiences. I want to thank especially the Public Health Committee here and for Dr. Pettit, because there was a friendly amendment in committee when it came out to just really add additional safeguards to make sure, one, that all the money was vetted by the Attorney General so that he can ensure compliance, he or she can ensure compliance with the legal agreement and the intent that this goes to future remediation, and two, extra protocols and safeguards put in place to ensure that this funding is on top of and not supplanting investments that were already intended through the general fund. So really happy to see that move forward. And we'll have to get that committee up and running in quick order so that we can make good investments on our opioid settlement money. Turning to the next tranche of bills, I want to touch on some of the highlights from Medicaid and private insurance perspective. Several people on the cabinet call today have been vocal champions and advocated very forcefully and successfully to make sure that those immigrants and undocumented children had access to a healthcare program equivalent to what children under Medicaid would be able to receive. So you all may be familiar with the fact that going into this year, we had anticipated that starting January 1, there would be coverage regardless of immigration status for children up to age 8. In this budget, that is extended further to children up to age 12. The budget implementing language also includes a grandfathering provision so that any child who is eligible and on the program at age 12 would be able to continue eligibility up to the age of 19. So really want to give credit to a lot of the advocates. I know Jill Zorn is on here, and Vicki has worked closely with them in investigating how we can make healthcare an option, a real option for those who may not be eligible otherwise because of immigration status, and know that DSS is going to be doing lion's share of work in quick order to make that happen, but very important work on that regard. In terms of some dental rate increases, we have flagged that on the adult side, there were some access issues and it merited having a little bit of an increase on the Medicaid adult dental rates. A 25% increase is provided for in the budget. Additional increases are made available for adult rates for endodontics care, so root canals and other such procedures. Not an investment of funding, but a policy change was to make sure that there's streamlined access to dental care, preventative dental care services, especially when they're provided at FQHCs. So we have some language that makes it clear that if someone is going for non-emergency periodic dental care, where possible, those services are bundled to avoid multiple repeat visits. We know that it's sometimes a burden on Medicaid clients who are asked to return back to an FQHC multiple times for things that typically would be done in the same visit. So when we think about screenings, examinations, prophylaxis, and radiographs, that where possible, absent a medical necessity or an emergency of some sort, we try to bundle those services to reduce the burden on the Medicaid clients. There's also provisions in Senate Bill 2 that expand coverage for certain services that are provided by associate licensed behavioral health clinicians. So that would include licensed marital and family therapy associate, a master of social work, or a professional counselor associate. And obviously these associate clinicians would be working under the supervision of an enrolled independent behavioral health clinician, and they would have to be operating within their scope of practice and in comportment with supervision laws in the state. There are some insurance mandates. Senate Bill 358, advocated by a lot of community partners that wanted to make sure that insurance coverage was appropriate and enhanced for certain mammograms, ultrasound, MRIs, additional coverage requirements for certain breast cancer treatment procedures, as well as testing and treatment for ovarian cancer. One last point I'll raise in terms of insurance, and this is directly related to my division at OPM. So we are going to be working with the Department of Insurance to look at whether there's a possibility to contain cost of the long-term care partnership plans through the use of captive insurers. And we'll work closely with CID and also look at what other recommendations can be made to contain costs and premium rate increases for the long-term care partnership policies that we have in the state. Moving on to the next slide, I will highlight just some of the health delivery and practitioner and facility impacted legislation. Strike planning and preparation. So last time when there was anticipated large-scale strikes at nursing homes, DPH identified that there were some issues in nursing homes not always planning for the appropriate level of staffing. And we were concerned at that time that this could lead to potential transfers of individuals out of their home and into other facilities, including potentially even out of state if the staffing wasn't particularly provided for. So we enhance the requirements of nursing facilities and other healthcare facilities so that when there's a strike or a potential strike, they provide as part of their strike plans a minimum of 3 days of staffing, and that they do so at least 5 days in advance. They provide that plan to DPH to give us adequate time to ensure consumer resident safety and that there's adequate preparations put into place. Related to some scope of practice issues, Connecticut is one of only 16 states plus the District of Columbia that does not regulate the practice of non-nurse midwifery. And so the best approach we thought was to take on what Connecticut typically does when we look at scope of practice and create a scope of practice review-like process that would engage stakeholders, people with direct lived experiences or expertise in the profession, and go through a process that will look at what are the range of options that Connecticut could consider and the legislature could adapt for a regulatory framework for this profession. And we go into this with no preconceived notions of what that may be. It could range from a certificate program or registration all the way up to a full licensure type process. So we will engage in that process and be back to the legislature with input and feedback. Related to that, one of the things we have identified in the scope of practice review is that the deadlines as they were previously written are heavy on some of the process and procedure timelines at the front end of the process. And what that did is it took valuable time away from the committee and DPH to actually do the investigation, the writing, the substantive engagement in the meat of the matter. So we've adjusted the timelines for scope of practice reviews so that there's more time on getting to the substantive issues and writing the recommendations and report. And we shorten up by a couple of weeks some of the initial notification requirements and postings at the front end of the process. Community benefits, I see we have friends from the Hospital Association and Melissa Olson on with us, who was a real valuable partner in helping to frame up the way we do community benefits programs that they're administered by hospitals. The ACA requires these community benefits programs, but doesn't put a lot of structure to how we can assess them and make sure that there's equity built in and that community has meaningful input in the development of them. So we worked constructively here. And again, I have to thank Edie Veltri for leading the charge in making the community benefits program requirement a lot more transparent and meaningful in Connecticut. And we do that as part of the various revisions bill, section 50. Vicki, I don't know, do you want to add any more? I know this was a collaborative process and one that we got the support of the Hospital Association on as well.
Yeah, I would just add that it was a negotiated bill over a couple sessions. And I also want to call out Health Equity Solutions that played a role here to get this bill over the finish line. So that's about it. Stay tuned. There's a lot of work to be done on this one.
Great, thank you. Also, one of the recommendations, another one that was incorporated into the DPH various revisions, was about medical diagnostic equipment and how we can make sure that when we're purchasing new equipment at hospitals and outpatient clinics, long-term care facilities, we're doing so with the best guidance and recommendations of federal and national experts, and making sure that those equipment are accessible. And so this bill simply requires that when hospitals or outpatient clinics, long-term care facilities, or hospice facilities are purchasing new equipment, that they take into consideration national benchmarks and best practices, including those established through the ACA by the Federal Architectural and Transportation Barrier Compliance Board. DPH is also authorized to implement regulations as needed once standards have been adopted at the federal level. A lot of members of the disability community and advocates of seniors were supportive of this way to think about medical equipment in a more equitable and accessible fashion. Certificate of Need Task Force, there's a couple things that happen with Certificate of Need. This one is related to the work that Office of Health Strategy will do to undertake a study and develop recommendations. They're tasked in the bill with very specific areas to look at and to make recommendations on, including whether the institution of a price increase cap that is tied to cost growth benchmarks should be made as part of consolidations, whether local representation of communities on hospital boards is something that's required, Attorney General's authority as it relates to CON applications and complaints, and various penalties for noncompliance, including increasing staffing needs. So there's a host of recommendations that they'll be coming out with. There's also part of 5001, the House's major early childhood development and behavioral health bill, a process by which for a very short period of time, if an existing behavioral health provider wants to expand out behavioral health capacity, they would have to fill out a form as prescribed by OHS and be able to do so without a more formal review of CON to build out and add new capacity. There will also be, as part of that process, an investigation as to whether, if any recommendations should be made regarding an expedited process for behavioral health providers to do expanded CON. Vicki, CON,
yeah, can I just jump in for 1 second? So the task force, by the way, is through the insurance committee, who is charged with staffing it and chairing it. But two things important on that exception process, so to speak, for the behavioral health facilities. Criteria includes accepting coverage for Husky and commercial insurance, which is absolutely critical for these facilities to do. We want more access, but you got to take coverage so people can have true access to care. But an important piece that also passed related to CON is the definition of a termination in state law. So if any service is suspended for more than 180 days, it will be considered a termination under CON. So that was a very big definitional piece that passed also as part of that entire section related to CON.
Thanks, Vicki. Appreciate that. Then continuing on to Senate Bill 450, Connecticut Valley and Whiting Hospital. This bill does a couple of things. One, it ensures that there'll be a plan developed by DEMIS for the creation of a new facility for DEMIS Hospital. It will reconstitute an oversight body to look at and do annual reporting to the legislature, including any investigations and recommendations that would be made for ensuring safety, quality of care at Whiting Forensic Hospital. It also adds to the standard that a court or a PSRB, a Psychiatric Security Review Board, would consider when making a determination of initial commitment, confinement, or conditional release. So previously, under current law, the only factor that was taken into account is protection of society. Now, moving forward, there will also be consideration for an acquittee's safety and well-being as part of that consideration. There's also a handful of other due process protections and reforms that come out of the working group and public hearings that the Public Health Committee had. Temporary nursing services agencies. One of the things during the pandemic that became pretty customary was tapping into these temporary nursing staffing agencies to fill short-term needs and gaps in the workforce. And this was particularly an issue in the nursing home industry that had pointed out the costs and the increased costs of using these temporary nurse staffing agencies. So as part of this bill, we are now establishing through DPH a registration and reporting system for temporary nursing services agencies. Part of the role that DPH will do is also establish minimum qualifications for those agencies. It will also collect reports that itemize revenue and costs, the average number of nurses employed by those agencies, average fees, and the residency of the nursing personnel. This is really important because we want to understand, are these temporary staffing agencies made up mostly of Connecticut nurses that are using that instead of permanent placement at a healthcare facility, or are they really coming from a host of other outside states? And that'll be, depending on what we find out from this data collection, the policy prescriptions and approaches could be very, very different. So we want to make sure that we were operating with the right set of facts going into that process. There's also an opportunity for DSS to look specifically at how the temporary nursing services agencies' rates and costs impact nursing homes and if any recommendations should be made or considered in that respect. This bill also became a vehicle for a number of other aging committee priorities, so well beyond just the temporary staffing piece. There were pieces added here that the long-term care ombudsman had requested that require nursing homes and residential care homes to electronically report involuntary transfers or discharges to the ombudsman so that they can more quickly look to make sure that there was continuity of care and seamless transitions. There's also a managed residential care work group as part of that bill, and requirements beefed up for mandatory reporters to complete elder abuse trainings. Two more things that come to us from the provider set that I want to touch on. One is the no hire clauses. In 2019, the legislature passed a law prohibiting non-compete clauses to be part of contracts with home care workers. What has come to our attention from a number of consumers is that the industry was working around some of those non-compete clauses by putting clauses in contracts with families and with the caregivers that would prohibit them from hiring a care worker that was provided by an agency. So to close that loophole and ensure that everyone was operating on a level playing field and that individuals could hire and choose whoever they wanted to hire in terms of their elder care without financial penalty, this bill simply prohibits non-hire clauses from a consumer's contract. Immunization information system. I'll just quickly say here that we have in the state of Connecticut operated a CT-WIZ program that tracks vaccination records. Under current law, this applies to children age 5 and under. We saw during the COVID pandemic and the need for mass vaccination of adults that it probably makes sense to make sure that the systems we have in place can also be applicable to individuals of all ages and all vaccines. So this would bring in capacity for adult vaccinations to be also managed under that CT-WIS. This gives people a centralized access point to their own personal vaccine records. I know a lot of us may have gotten boosters at different spots than we got our initial ones. And so to avoid that fragmentation and to create a centralized repository, this will help us do that. It also helps inform some targeted vaccine outreach and prepare on a population health basis for any outbreaks that may occur. Moving on to our last I think we need to do one more. I think we covered this stuff. So is that our last slide? No.
No, there's another slide. Maida, are you able to advance? There you go, I think.
All right. So here, I know we're running really short on time, so I'm going to try to highlight a few of the most important ones. Obviously, written consent is going to be required. There's a requirement that hospitals and providers do an adoption of an electronic consent form for any intimate examination that would occur when a patient is unconscious. Residential care homes, transfers, and discharge. This has been a piece of legislation that we've tried for a number of years to get in place. Very important that it happened this year because there are federal requirements that set a standard for what can count as a home and community-based setting, the home setting rule at the federal level. And one of the touchstones of that is ensuring that people in, for example, a residential care home have comparable rights when it comes to involuntary discharges as an individual would have under the state's landlord-tenant laws. So this bill, this provision here in various revisions puts us into compliance with the CMS standard, allowing 250 or so elders who receive waiver services and RCHs to continue to receive those services without disruption. More importantly, it enhances the process rights and the appeals rights for a resident of a residential care home if they are involuntarily subject of an involuntary discharge. Just add a little bit in terms of the opioid epidemic bill. This is an important companion bill that came out of the Public Health Committee that would look to expand out some of the services that are available in opioids, including making sure that certain testing strips are removed from the definition of drug paraphernalia. So fentanyl strips, testing strips would not be included as the definition of drug paraphernalia anymore. It also allows for certain methadone and other behavioral health services to be dispersed through mobile units for ease of accessibility and reaching hard to reach communities. Finally, I want to just note the long-term care ombudsman. We've gotten to a point in our state where about 70% of our home and community of our long-term care services are directed in home and community-based settings. And it seems overdue that the regulatory regime should be able to keep up with that. So up to this legislation passing, there was no dedicated point person that individuals who are receiving home and community-based services could go to as an advocate for information or for quality checks or oversight. We are now creating for the first time a dedicated long-term care community ombudsman. Some of you who are following the Build Back Better bill may recall that as part of that bill, there was going to be long-term incentives for states to rebalance and do more home and community-based care. And one of the conditions of that was they wanted states to build out an apparatus and infrastructure to do oversight and quality assurance and protect those consumers who are receiving care in the community. We have, even despite that bill being stalled out and not passed at the federal level, we thought it was important that Connecticut lead the way and at least build the infrastructure so that should that ever happen, or should we have the resources to continue to scale up, we're starting to at least have one person do advocacy for those consumers in HCBS settings. So with that, I think I have 2 minutes left. I'll just conclude by saying, I think obviously I didn't cover every health or human services related issue. And as I said from the top, I think that some of these really deserve additional conversations, even dedicated sessions, just to do a deep dive. I especially think around the behavioral health space that we should bring in experts from a number of agencies. SDE has a portion of those bills, DSS, OHS, and DPH, and just really make sure that we're fully maximizing the opportunities with these new pieces of legislation that are going in.
No, Claudia, thank you so much. There's a reason we have an undersecretary of HHS over at OPM. Thank you for all the detail. And next meeting, everybody has to come back with all their bills memorized. I'm just kidding. That would be impossible, but I agree with you. We need to have some deep dives. Ted has a comment.
Yeah, thanks, Vicki. And I know we're at time. Just real quick, in addition to all those great bills that Claudia went through, one that is potentially transformational. And for those of you, especially newer on the cabinet, my name is Ted Doolittle. I'm the head of the State Office of the Healthcare Advocate. We provide essentially constituent services to anybody who is fighting with their health insurance company. So if you have a claim denial, we have a team of nurses, paralegals, others that can represent you for free. Part of HB 5001 was Section 71. And again, kudos to the Public Health Committee. That provides for enhanced notifications about my office. Already in statute, there is the requirement on claim denials for insured and other documents for insurers to include our name and address. It usually winds up back near the alternative language. This is potentially transformational in that it gives us the opportunity to have a call out box on the front page of claim denials with language that we, the Office of the Healthcare Advocate, specify. I want to thank the Speaker's office in particular.
What happened to Ted? He disappeared. Ted, come in. Okay, does anybody see Ted? No.
No.
Okay, well, I think he was trying to thank the Speaker's office, so we'll thank the Speaker on behalf of him. We are at time. I want to thank everybody. I know I'm surprised we actually used all the time, but we did. We will be back next month. Maybe we'll do some deeper dives, and I also just want to throw out that we may be back to working with the cabinet on a study. Our office is working through one of the studies that we were charged with. We may want to bring that to the cabinet to assist us with it. And that's the one on telehealth. So stay tuned on that one. We'll try to package that up a little bit before we come back and talk in more detail on it. But with that, since we hit the time, if folks have additional input or topics for next meeting, please send them our way. But I will ask for a motion to adjourn.
So moved, Jill.
Thank you, Jill. Is there a second, please? Someone? Anyone? Thank you,
Jill.
Cassandra or Nichelle. Thank you, Nichelle. Thank you. And with that, we are adjourned. Thank you, everybody, for joining the meeting, and we will see you next month. Take care, everyone. Bye-bye.